Good evening, everybody. Welcome to this meeting of the Health and Adult Social Care Overview and Scrutiny Committee. Got a number of people joining us online, so everybody's very welcome. My name is Councillor Patrick Canavan, and I'm going to start by asking the Democratic Services Officer if she would read the housekeeping notice, please.
Thank you, Chair. Please note that this meeting is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. The meeting may also be recorded or streamed for live or subsequent broadcast by members of the public, although ultimate discretion in this matter lies with the Chair in case of disruption. For those in the room, please note that if the fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the assembly point in the front of the car park of this building. Finally, please ensure background noise is kept to a minimum. Mobile phones and other devices are switched off or turned to silent for the duration of the meeting, and for those in the room, that includes turning off microphones and turning down volumes on laptops completely. Thank you.
Thank you very much. Are there any apologies for absence?
Yes, Chair. Louise Bates from Health Watch has sent her apologies, and Councillor Matthews is joining online this evening.
So just to confirm, no substitutes?
No substitutes, Chair.
Thank you very much indeed. Move on then to the usual item of declarations of interest. If committee members have any declarations, could they please? Councillor Salmon.
Yeah, so I work for Dorset Healthcare.
Thank you. Councillor Allen.
I'd like to declare that I work for University Hospitals Dorset.
Thank you very much indeed. I'm going to move on then to the confirmation of the minutes. So unless anybody has any concerns, may I take the minutes of the meeting held on the 2nd December as a correct record?
Yes, agreed.
Everybody content?
Agreed.
Thank you very much. And similarly with the action sheet, is everybody happy that that represents a true and accurate record and we can accept that? Thank you. And are there any public issues?
There are no public issues, Chair.
Thank you very much. So we're moving swiftly on to the transformation of the UHD hospitals. And I'm going to invite Richard Renaud, Chief of Strategy and Transformation at UHD, to present this item for us. Thank you. Thank you, Richard.
Thank you very much, Chair. Can you hear me okay?
That's fine, thank you.
Yeah. Brilliant, thank you. That's great, thank you. So the pack is in the papers that you've got. So I will go for that briefly, but I think it's much more interesting and lively to have questions. So happy to give the majority of time to that. But firstly, just say thank you for having me and thank you for allowing me to present remotely. We are doing a series of sort of public engagement events. So I'm actually going to the one at Christchurch this evening. But we are at the cusp of the biggest change in hospital services in the BCP area since the late 1980s. So those of us who were around then will know that that was a major period of change, and it's really the biggest, say, in 35 years. We're looking at some major changes happening at the end of this month, which are very exciting, and then a further set of changes early next year, where we will complete our work started back in 2015 around creating the planned and emergency hospitals, and as a result have secured over £500 million of investment into Dorset. So it really is a very significant moment and a major improvement for patient services. So if it's okay, I was going to very rapidly go through the pack. Obviously, to emphasise that we're just one part of the wider health and social care system, and that we are very wedded and committed to the vision around Dorset being the healthiest place to live in the UK, which we think is achievable, ambitious but achievable. And this is part of that journey. And having good hospital services is a small but important part of achieving those healthy aims. You probably know the locality, and there's a little bit about University Hospitals Dorset and a little bit more information about the sort of number of patients and treatments and births, for instance, that we deliver for the population each year. I'm just going to pause on this slide. This is the very busy slide, and it is the slide that is, could you fit everything onto one page, please, slide. And effectively on the left here is all the things that have already happened, which I'll touch on in a minute. And then here is our road to what's happening. And this yellow block here is what's happening, as I say, very shortly. So we have the new CT and X-ray starting this week at Bournemouth Hospital in our new beach building, with our critical care moving in, followed by the first bursts at the end of this month, beginning of next month, and then the Bournemouth ED moving in May. And then a series of other changes happening, and as I've mentioned, the really big moves when emergency and planned care services change around about January, February time next calendar year, and that will be probably the most significant changes. And very happy to provide updates as we get nearer to that date. And that would be building on some of the services already changed, like stroke and cardiology, which have already moved. But that isn't the end of the story. Two other significant things still to happen. Major works at Paul, which can only start once some of the services have moved to the new build in Bournemouth. And that then allows us to complete the surgical hub. That will be 2 whole floors being completely refurbished and built, and also the new endoscopy unit opening at Poole. So lots of investment activity in Poole. And also just down here, we've got the electronic health record, which will be a major change in the way that every patient interaction is recorded and supporting clinicians in their decision making. So again, a major investment in technology. So that's the timeline. So we're busy with change up till 2027 in our services and our estates. And then I was just going to very briefly say there's obviously a lot of good reasons why we're making all these changes, and we are very mindful that change is disruptive both for patients and staff. And so really just to remind ourselves, when we started on this back in 2015-16, these were some of the main benefits, particularly at Poole, to reduce waiting times and reduce cancellations from having a planned care hospital, and at the Bournemouth site having our dedicated emergency services, a brand new maternity unit, which will mean better quality of care, better environment for that care, but also a lot of patients at the moment currently have to move between sites, so that is already beginning to reduce. And then across the piece, as part of our merger, we've brought together and made sustainable a lot more of our services. And across the NHS, it means we can just be a better partner, able to provide more resilient services. So as you can see, we will become the UK's largest planned care hospital, doing complex operations, which normally can't be done in a planned only site, plus, say, increased endoscopy and diagnostics. So those benefits are listed there, and the site changing, as I said, 2 floors in the middle still to be done as major refurbishments, and the endoscopy at the back of the site here, which is was the old ambulance station. And then on the Bournemouth site, for those that you've been by recently, you'll know at the front of the site we've got the beach building. That's the building that's opening, as I say, for the diagnostics starting this week, and the rest of the services over the next few weeks. But where we've got coloured, these are all the other service changes which are happening, including the road, which should open this week. And we have also the pathology hub, which is already built. And again, with BCP Council's crucial support, we're able to secure the land and place that on there. And there's a picture of the pathology hub. The other building is, most you might have seen as well, similar height to the beach building at the front, is the Coast building. And the Coast building is our ward block with catering on the ground floor. This is an artist's impression, but already the infrastructure is built, and that will be completed by the end of this calendar year. And that will allow this site to move from a 500 to or 550 to an 1100 bed site, so major teaching hospital size facility. So inside the beach, here are our new CT scanners, one of them supported by a charity, which we're very, very grateful for the public. We have operating theatres, we have our critical care unit, so fantastic new facilities. And then again, the really big changes happening is that St Mary's staff will be celebrating the end of the building use at St Mary's in Poole and the transfer over to the Bournemouth site into their purpose-built facilities. Very exciting time, and staff obviously are all obviously keen that it goes well, but it is a huge amount of excitement, and we're actually at the highest level of staffing, lowest level of vacancies we've had for many years now, because it's actually helped us recruit and retain staff, because everyone wants to work in a new purpose-built building. So lots of information here and some of the benefits that are in the pack. And this is building on services that already changed. So stroke has already moved to a single site service. That has meant we've been able to consolidate all the expertise, and with new CT scanners means that patients are able to get faster care to access treatments, which make a huge difference to the long-term outcome for stroke. And equally in cardiology, we've massively improved the speed at which patients, particularly in the Poole area, can access the cardiac labs. And again, that is evidence to save lives. So finally, just to give you a brief summary, here is our timeline in a slightly more sort of detailed way than the roadmap, leading, as I say, to the winter of this year, where our new ward block opens. So it is an exciting time for staff. There will naturally be anxiety and an additional pressure on staff, and we do, again, very aware of the impact on patients who have, for the last 30 years or so, been used to how services are set up and configured across the conurbation. So it is a change, and that's why I'm very keen to take questions and help support you in your role as a panel in being briefed on this, but also being able to engage the public as we complete this part of the transformation journey. Thank you very much.
Thank you. Just look around the room to see if there are any questions.
Yes.
Richard, I wonder if I might ask you on the paper sets out the kind of vision and the targets. For example, the 55,000, or preventing 55,000 children becoming overweight by 2040. I just wondered within the plan whether you've got some kind of markers or checks or review process to see how all of that's going. Thank you.
Thank you. And I note that Sam Crow is on the call as well, so might need to phone a friend on that. But in terms of the mission around making Dorset the happy space to live, yes, there are some measures of childhood weight and some interventions that are being looked at to try and reduce that, because obviously that has a huge impact on life outcomes. I'm not sure whether Sam's able to come in, but if you want, I could come back with perhaps some more information on that, because that's led by, as I say, our ICS and public health colleagues to give you more information if that's helpful. Sorry, there's
Hi, good evening, everyone. I'm afraid I've had audio problems, so I've only literally just been able to get on and hear the meeting. So I don't know the whole context of the question, but happy to help if I can.
Sorry, Sam, this was just about, are there any milestones or targets for the of the 5 pillars, the reducing childhood obesity ambition that we set ourselves? So the chair was just asking if there's any measures that we're tracking on that programme.
Yeah, so it's a really good question. It's not one that I feel I could give a full answer to. The original idea behind the NHS Joint Forward Plan was that the work would be carried out through the delivery groups that report into each of the pillars. So at some point, I'd hope NHS Dorset would be able to come forward with more details about exactly what that work is. And that will, to some extent, need to also have those proxy indicators in. In terms of, I think you were talking about the childhood obesity measure. The thinking behind how we modelled the targets for that measure was very much about recognising that whatever we were doing across the whole of Dorset, BCP Council and Dorset Council, we were different to many other areas in England in that we'd had a lower prevalence of children at the 2 measurement points who were overweight or obese. So to some extent, we were saying if we can continue to do what we're doing really well, we should be able to hold off from seeing those rises in prevalence that other areas have had. But obviously, any additional investment, any new programs, any continued expansion of access to things like physical activity programs for children and young people will really help to hopefully keep those numbers down.
Thank you very much. Are there any other questions? Councillor Dedman.
Yes, thank you, Chairman. I've really read the report very well, Richie, if you don't mind me calling you that. We've known each other a while. And I can't see much about Christchurch. The two centres are going to be Bournemouth and Poole. Is Christchurch still going to exist on any level? Thank you.
Absolutely. I'm calling from Christchurch Hospital now. So yeah, absolutely. It will remain providing the range of service it does now. As you're aware, we are still keen and working with the Macmillan Care locally to try and raise the funds for the hospice rebuild. That's still an ambition that we're working towards. But Christchurch went through its changes, as you're aware, Councillor, a few years previous to all of this, and so has got no backlog and is in a good state. Things have continued to change, so there's been a major expansion of the physiotherapy services here, and we're looking at seeing what other diagnostic services we can put on the site. But the services continue to thrive around dermatology, rheumatology, day hospital, etc., as well as the sort of main outpatients. So we're Christchurch remains very much part of the chain of the services, but probably has less change in the next 2 years than the other sites.
Okay, thank you very much. Oh, Councillor Moriarty.
Thank you. Thank you. That was really, really interesting presentation and absolutely some fabulous work being done. Could I ask, is there going to be an overall net increase in the number of beds compared to 10 years ago? And what about A&E capacity? Because that's obviously a source of concern for a lot of residents. Thank you.
Thank you. Yes, great questions. Thank you. So as well as moving emergency services onto one site, it very significantly changes the pathways of care. So we are looking at a very large increase in what's known as same-day emergency care. So that's SDEC, same-day emergency care. That effectively is as sort of revolutionary as day surgery was 20 years ago, in that some patients who are admitted and might stay 1, 2, 3, 4 days to get the diagnosis, the treatment plan, the start of treatment, and supportive packages in place can actually be done in a day. So we're already providing more and more SDEC or same-day care for emergency patients. But what we will be doing is creating that capacity. So where the current emergency department is at the Bournemouth site and the offices above it will be completely removed and become that SDEC same-day service. So our capacity to see more patients won't be measured in the sort of in the space, but actually in the number of patients we see, and deliver the same levels of outputs and care and quality, but get people home the same day. And I think most people agree that, you know, being in your own bed, as long as you've got the diagnosis and the treatment plan and the medications and the support, but actually that's better than being in hospital for 3 or 4 days awaiting those things. So that's a major change to the way we provide services, and we're able to do that by bringing the two teams together that are currently split across Poole and Bournemouth. So that will mean we've got more capacity than we have now for emergency patients. Overall, our bed numbers are planning to be about the same, but we will instead have a much higher ratio of single rooms, which we know is better for patient privacy and dignity, but also for infection control. And that means that patients tend to spend less time in hospital. So we think that although we have a similar number of beds, the stock of quality of the estate will be much better. And so that will give us more capacity. And then the other part is that we're working with BCP and other colleagues with the Newton work that's now called Future Care. And that will be really trying to change the way emergency pathways work, and particularly reducing the fact that about 20% of our beds at any one time have patients who have no criteria to reside. So if we can reduce that, that would free up over 200 individuals who are in beds who don't need to be in acute hospital. So we've built overall the strategy on roughly the same number of beds, able to cope with future growth in population and ageing, but predicated on that better use of the capacity. I don't know if that is helpful or there's any sort of follow-up. That's it.
Incredibly helpful and very reassuring. Thank you.
Thank you, everyone. Any further questions? Councillor Brown.
Thank you, Chair. I know obviously I'm not a member of the Overview and Scrutiny Committee as the portfolio holder, but actually I wanted to just grab Richard for a moment just to ask a question about communication, because I think the communication of all these changes is really important, partly internal communication in UHD, but also to the public, because certainly conversations I've had even just this weekend with a doctor from Poole A&E about they're still getting patients appearing there with stroke symptoms, and it's not the best place for them to be turning up because Bournemouth's where all the expertise is for that. But also, you know, they as a doctor were reading last week online, and I know you shouldn't believe everything you read online about Poole Hospital closing. And I've seen it recently, you know, people are talking about Poole Hospital closing, and it's just couldn't be, I had to say to them, couldn't be further from the truth, you know. Millions and millions have been invested already, and there's more coming. So for me, it's a big, and I've noticed more on the sort of UHD social media promoting the changes, but I think there's still a good job to do about communicating to the public to really understand what these changes are and the benefits of them.
Yeah, thank you. Yes, that is it is a fair comment, and we can always do more. And partly coming here is feedback will be helpful in particular areas we can go. And as I say, I'm going to the Christchurch Residents Association tonight to talk about this as well, to get the word out. I think the immediate answer I give is that messaging around using 111, if you've got non-life-threatening situation, then 111 will provide the signposting, including to pharmacy or self-care, etc., or which emergency department to go to. Just to emphasise, and I think it was in the pack, but I'll just pick it up, point it out if not, Poole will still retain its 24/7 urgent treatment walk-in facility, so the public can still walk in. We would always advise, you know, ring 111 first, and they can direct you. And we can also importantly book your appointments, so you don't have to wait for hours in the waiting room. So that would be a common message we'd be keen if for your community leadership roles you're able to reinforce. And then as the changes happen and as we build towards early next year, when we have to say this sort of once in a generation shift and the emergencies at Poole and the elective plan works it. The emergencies at Bournemouth and the electric plan works at Poole. At that point, then we will also massively step up the communication and both through staff and through all our media channels. The reassurance we want to give obviously is that be a planned process, but inevitably, you know, people will still be turning up at one place or the other. But the key message is the ambulances and the ambulance crews obviously will be fully briefed so that they know to head to Bournemouth with the emergency care, as they do at the moment already with most ambulance strokes and cardiac cases. Where it's less clear cut, then they can ring and get advice in advance of deciding where to take the ambulance. But the wider point about communication is one that we're really keen to get feedback on, how we can connect, because often people won't pay attention until they need the care. And obviously our aim is to make it as helpful as possible. And we're undertaking other activities such as improved car parking, improved wayfinding, improved messaging. So we are keen for feedback, because we know we don't get it right all the time. So happy to maybe outside the meeting, any feedback equally welcome as to how we can improve.
Okay, thank you very much indeed. Any other questions? Councillor Salmon.
Oh, yeah, just one more on something you mentioned about booking into A&E through 111. Excuse me. So I wasn't aware that was being implemented at the moment. I know you can phone 111 and you may get a time slot, but I don't think they're blocked out. It's not like when you're booked into a treatment centre, is it? Or have things jumped forward with A&E?
Yeah, thank you. So yes, you're right. It is a time slot, but the particularly where we've got GPs working in the urgent treatment centres at both Bournemouth and Poole, the ability to book into those time slots and be seen by a GP or advanced nurse practitioner means that effectively you're not just arriving and then waiting your turn. So it does reduce the waits, but that also be down to the individual decision-making algorithm within the advice you're getting from the 111 team. We'll also be moving to more online and pre-booking processes to try and get as much information as possible in advance. So that is an area we're constantly under development. So, but I mean, the simple message is use 111 where it's not immediately life-threatening is generally gets you the best signposting.
Betty.
Yeah, thank you. Richard, I just wondered, I just wondered if it would be helpful to have an extended invitation to this committee members if they wanted to have a tour. I know you kindly did that with myself and the chair of this committee and the portfolio holder. But I think it might be something that other members of this committee might want to take up. And if that was okay with you, they could come through me and I could arrange that with you the way we did before.
Yes.
Thanks.
Thank you, Betty. I thought invites had already gone out. If members haven't received those, then I can send the dates round straight away, because we do have some next week and the week after if people are free.
Very good. So we'll just coordinate that to make sure that everybody can go who wants to. Thanks.
Thank you.
Thank you, Betty. So if anybody on the committee hasn't had that invitation, please let us know and we'll arrange for you to see it. There are different dates that you can opt to go and have a look round. It's well worth it if you can find the time. Are there any other questions on this report? If not, Richard, thank you very much indeed for your time. That's very helpful. Thank you very much.
Thank you.
So we're going to move on to the public health disaggregation progress and overview of decisions. So I'm going to invite Sam Crowe. This is actually a paper that went to Cabinet on the 5th of February, but I thought it would be helpful for the committee to just have a look at it, and very grateful to Sam for being able to join us on what is his first day as acting chief executive of Dorset Council. So I'm sure it's been a wee bit busy. Thank you, Sam. Over to you.
Thank you very much, Chair, and good evening, committee members. So I'm happy to give a brief introduction and overview, but I wasn't intending to go too deep into the detail, but I am happy to obviously answer members' questions. As the Chair said, by way of introduction, I believe this paper went to BCP Council's Cabinet on the 5th of February, and a mirror paper has also gone through Dorset Council's Cabinet in the last week. And so what you have in front of you is oversight of the process that we've been following right from the point at which back in 2024 in April, when BCP Council served notice on the arrangements for the shared public health service, the work that we've had to do between the two councils to disentangle what's been quite a complex service. Just by way of context, the shared public health service had been operating for more than a decade. So over that time, it's perhaps unsurprising that we resembled a genuine pan-Dorset service serving those two councils with a lot of commissioning across both the council footprints. But the real challenge, I think, has actually been the public health team and finding a way to come up with a legal and fair HR process to disaggregate that team properly so that both councils have an effective public health service going forwards has probably been one of the biggest challenges. But we're making really, really good progress, as you'll see from the paper. My view is that this process has actually been carried out really effectively between the two councils. I'd like to pay tribute to all of the officers that have been involved in supporting that work. Gillian Kay, as your Corporate Director for Wellbeing, has been the Senior Responsible Officer for BCP Council. Aidan Dunn, who's the Executive Director for Corporate Development, has been the Dorset Council equivalent. But I'd also like to thank the programme managers, Harry Ovnick in BCP Council and Steve Stone on the Dorset Council side, because they've really made sure that through the steering group and the programme group, we've managed to keep going through the business and get the necessary decisions made in a timely fashion. So in terms of pragmatism, you'll see from the paper that we, right from the start, took the approach of trying to focus on getting early agreement on the financial agreement, which underpins the shared service, and to come up with a fair way of treating the money as we go forward. We came up with a 55-45 split in favour of BCP Council, and that reflected the partner council's contributions into the shared service. So that was agreed really early on. We also took the pragmatic step of not worrying too much about disaggregating complex large contracts, but leaving that to what we call phase 2. Instead, we focused on how we would support the team to go through an HR process that would see the establishment of 2 new teams under 2 new directors of public health from the 1st of April 2025. Once we get past that point, there's still quite a lot of design work that has to be done in both councils with the 2 new directors of public health to start to think about how the public health team will work effectively in those single councils. And that will also include starting to look at those services and contracts that we provide in common. And the agreement was reached through the steering committee that we would start to treat those almost as the expiry periods come up. So whenever some of our large contracts are due for renewal, we will work together and we will collaborate on developing options for the best way of continuing to commission those contracts going forward. But that's very much after the 1st of April. What the paper that went to both cabinets was really trying to do was to give assurance on the process that's been followed to date, but also give members the chance to endorse some of the officer recommendations around some key decisions in relation to a number of smaller contracts that needed extending. And the main decision was probably in relation to the Live Well Dorset service, which has been a public health in-house provider service for a number of years. We came to both cabinets with the recommendation that that should continue to be supported by both councils, and I'm pleased to say that both cabinets endorsed that approach. So it will remain a public health provider service hosted by Dorset Council, but you will start to see a change as we go past the 1st of April, in that we'll move towards more of a formal commissioning arrangement with Live Well Dorset. So I'm happy to sort of pause there. I realise there's quite a lot in the paper, but hopefully those recommendations are fairly straightforward. Perhaps some of the questions might be more focused on exactly where we are in the process, because at the time of writing, the HR process hadn't yet completed. So I'm happy to pause there, Chair, and take any questions from members.
Thank you, Sam. Would you be able to give us an update on where we are with the staffing and whether we're now at a point where we know who's going where, if that's possible?
Yeah, we're not quite at a point where I can say in public exactly who's going where, but I can talk in general terms about what stage of the process we're at. So I think it's fair to say that this was quite a complex disaggregation of the team, because TUPE didn't apply. That was the legal opinion sought by both councils. So usually where you have a group of employees who are working in a very clearly defined role, often a geographically defined role, if they're destined for another organisation, it's quite easy to be able to scoop them up under TUPE regulations and transfer them with that undertaking. The legal advice was quite clear that that didn't apply in this instance, mainly because the team had been working in a genuine pan-Dorset way. So because of that, we had to come up with a way that was inviting the team to preference for both councils. There are enough roles across the 2 public health teams so that everyone will get a job in public health. The challenge is that not everyone will get their first choice through that preferencing, if that makes sense. So we've been going through a process where through the consultation process, the team have been supported to understand how to express a preference, what the future implications of working for both councils will mean. We've literally just closed that process today. So I can give assurance tonight that BCP Council will have public health team at most levels within the shared service. So we developed 2 interim structures, which were Director of Public Health, consultant level practitioners, heads of programs who are sort of most senior resource managers, if you like, in the organisation, and then a number of public health practitioners, which are divided up into senior health programme advisors and health programme advisors. Through the preferencing process, we have a fair spread of numbers supporting both councils, with the exception of the consultant in public health group. Unfortunately, we are going to have to do a number of interviews based on the fact that most consultants have preference for Dorset Council at this stage, and the result of those interviews will then be able to start to slot people in, hopefully under both of those councils. But that work's only really beginning, and the interviews will only take place from the 10th of March onwards. So at this stage, I can't say anything more about individuals, but I'd like to give assurance to committee tonight that the public health teams will be balanced.
Thank you, Sam. Are there any questions? Councillor Moriarty.
Thank you, Chair. One is a comment, really, and the other is a query, really. I just, first of all, want to say I very much welcome the fact that you're continuing the breastfeeding network. I think it's really important to kind of redress that kind of imbalance in the socioeconomic levels of people who breastfeed. So it's really, I think that's wonderful. The other is a query about adult weight management. And I'm wondering, because I know there's a couple of providers that you use, Second Nature and Slimming World. Do we have any hard data that they work? Because my understanding, it's only anecdotal, is that they're not very effective. But just wondered, do we have any hard data? Thanks.
Yeah, it's a really good question. So the weight management contracts that are referred to in this paper are a small part of the overall pathway. So everyone who is seeking support for helping to manage their weight usually comes through the Live Well Dorset front door, and Live Well Dorset work very closely with those providers. So where they recommend that someone does go to a provider like Slimming World or Second Nature, that is only part of the support that they receive. And we collect data on the results of the whole pathway, which does tend to show that, at least over the short term, they can be very effective in helping people maintain their weight. The challenge we have with all services is the longer term follow-up of outcomes, and that's very common in lots of health improvement services. When people are very keen and when people are very engaged, or if they've made a major change and they're still succeeding in that change, they're often quite happy to remain in contact with the provider and respond to those requests to let us know how they're getting on. The further and further away you get from their original point of referral, usually we hear back from fewer and fewer people. So I can give assurance that in the short term, the performance around those weight management services is actually very good. Over the longer term, it's well documented in many services that is actually quite difficult to measure effectively. As you know, I'm sure lots of people potentially relapse and have to go through several different sources of support before they finally make the necessary lifestyle changes to keep the weight off significantly.
Thank you for the clarification, Sam. That's useful.
Thank you very much, Sam. Any other questions, Councillor?
Thank you, Chair. Can I just ask, the Treating Tobacco Dependency programme, does that include vaping as well? Because some vapes are addictive as well, aren't they?
So treating tobacco dependency is the name given to the work that we do mainly in NHS settings. So it's funded through money that came through the NHS long-term plan. And it's the work that is done in the acute hospital settings and in maternity pathways to try to support people who are screened on admission and who still may be smoking. And it connects people up with nicotine replacement therapy as quickly as possible so that they're not smoking while they're in hospital. And it also provides people with the opportunity to have longer term support for their smoking. when you talk about vaping, the current stance in public health is that when someone is smoking and wants to try to quit, and among those methods of nicotine replacement therapy, they're keen to switch to something like vaping to get their nicotine because it's less harmful overall than smoking. That's an approach that we support, and it's helped many, many people in cohorts who wouldn't normally come forward for smoking support services successfully make the shift and stop smoking tobacco, which is much more harmful, and progress to using vapes. Our stance, though, is that vaping isn't appropriate for anyone who doesn't smoke because, as you've said, it is an addictive substance, nicotine, and there's really no sense in seeing people who don't smoke take up vaping. So we're very careful about the groups in who we would propose taking up vaping.
Thank you. Any other questions? If not, Sam, thank you very much indeed for your help with that. And we will move on. So we're going to move on to item 8, which is the adult social care strategy. And I'm going to invite Nikki Mitchell, Head of Transformation and Integration, to present the item, please.
Thank you. Hi, good evening, everyone. I have got a short presentation. I'm going to share my screen for you. Bear with me 2 minutes. So yeah, thank you. Hopefully you will have read the papers and the new draft adult social care strategy that's coming here for comment and then going to Cabinet on the 2nd of April, hopefully for final sign-off. But I just wanted to talk you through the process really and how we've got to this point and developed this strategy. So we're going in line with our corporate plan and our transformation plans. Obviously, we're linking it very closely to the corporate strategy, in particular the Our People and Communities theme, which focuses on people having a high quality of life, those that need support receive it and where they need it and so on. I'm not going to read it all out because I'm sure you're all very familiar with it. So we developed our vision. The logo you'll see on the left there, hopefully you'll recognise it. It's our Fulfilled Lives transformation programme, and we wanted to, very much base our strategy on our transformation plans over the next coming years, because we've obviously got an awful lot going on already. We spent a lot of work building up our transformation plans, so we know where we want to go. There's measures already in place. We did a lot of engagement with our staff and people, tested out our vision. We had a staff engagement event where we asked staff what they thought a fulfilled life meant to people, what they thought the vision should be. We also tested it with some of our focus groups that are made up of people and carers. And we also engaged with and considered our relationship that we have with Social Care Futures, which is the box on the right. Social Care Futures, for those of you that don't know, are organisation made up of people with lived experience, and they do an awful lot of engagement themselves, developing their vision, and this is their vision statement. So we try to encompass what staff have told us, what people have told us, and our Fulfilled Lives transformation programme to come up with our vision. And our vision is hopefully supporting people to live a fulfilled life in a place that they choose and where they feel safe. And just that bit there in a place that they choose, some of the engagement we had originally in a place they called home, but some people were saying, well, I don't feel safe in my home, or that might not be appropriate for me. So we took that on board and we said, okay, well, let's say in a place what you choose. So this is just a little bit more about the transformation, how we've aligned that. So we've come up with 3 areas of focus, and our transformation plans, we've kind of pulled them all into 3 different areas of focus. So one is putting people, carers and families first, where we will listen, build good relationships with people so we understand what matters to them, and that's very much building on our strengths-based approach to social care and our 3 conversations model, which we are transforming the way we work. Living in a place called home, so we'll help people to connect with their family, friends and community. We're in a place where they feel safe and at home, and we have included the word home there because that is important for a lot of people, but it is also about that community and those friends and family that people connect with, and our role as social care and how we help people to do that. Developing how we work. So this is about our creativity and innovative solutions and being creative with our resources, and also understanding and measuring that impact that we have on people and the services, the services that we're offering. How is that impacting on people? So we know that we're providing the right services and we're making the right decisions when we're designing our services. This slide just is a myriad of logos and icons, but I just wanted to show you just some of the engagement that we did over this course of this strategy development. We did telephone surveys, provider forums, focus groups. I'm not going to read it all out. You can see there at a bit of a glance just some of the people that we engaged with and some of the local and national organisations that we took inspiration from as well. So the consultation results, we did quite a lot of engagement. We had 302 surveys completed. 23 of those were easy read surveys. For the first time we had an easy read online version, which was something that we've trialled and that the consultation team are now going to use for the rest of the council moving forward. So that was a first thing that we tried, but it was really welcomed. We had, well, you can see there 1,212 views of the consultation webpage. We reached over 33,000 people via social media and our communications channels. We did 12 drop-in sessions across the whole of Bournemouth, Christchurch and Poole. We went to the libraries, some of the day opportunities places, and actually we had 103 people scan the QR code, which we were really pleased with as well, because that's a really easy way to get people engaged. The results, just very briefly, I have included as an appendix the full consultation report, so I'm not going to go through every single result, but you'll see there that majority of people did vastly support our vision and our 3 areas of focus. The one that was least supportive was developing the way we work, but I'm listening or reading to some of the comments and some of the engagement events that I did. I think people were less worried about how we were going to work. They wanted to hear about what we were going to do for them. But even so, vast majority of people did agree with it. We did make changes because of the consultation. We've adapted a lot of our language. So some people didn't understand what we were trying to say, as far as we were trying to write it in plain English, but we as officers are used to using probably fancy words or jargon, so despite the fact that we tried to not do that, there were still some things that that slipped through. For example, sorry, I've put divers there, it should be diverse provider market. People didn't know what we meant by that, so not divers. We increased representation of our carers, so where we had support for people, we automatically meant carers as well, but people didn't understand that, so we've made it read people and carers, so people know that carers is included throughout. People said that they felt that they wanted choice, so we've added that in as a new ambition. And generally comments, the more challenging comments we had from people were about how we're going to deliver that. It felt very ambitious, sounds all, great things that people would love to see, but how are we going to deliver it? And so we're considering now how we give people updates, so how we give the community updates on our delivery plans. There are extensive delivery plans behind this strategy, but how do we inform the members of the public so they're reassured along the way how we're doing? We've also introduced through this strategy Your Voice Network as part of the consultation. It's included in the strategy document. It's now on the website, so very much encouraging people to join that. We've had 95 people join already, and this is a network for people that receive services or family members of those people, or anyone that has an interest in social care, where they can tell us that they would like to be involved in developing services, or I've given some examples there of things that they might want to be involved in or able to be involved in moving forward in terms of co-production. So when those people join us, then we keep them engaged with focus groups and other pieces of work. So 95 people already, which is very exciting. Building on already, we had about 100 people already. So that's, it's a good piece of work there. So I think that's it. I've just got a couple of links there if anyone wanted to see the old strategy. But yeah, that's it for my presentation. A bit of a whistle-stop tour, but hopefully that helps kind of put some context to it.
Thank you very much indeed. Apologies if you've had some feedback. I need a shout out to the Deaf Club because I can't hear you without this bit of kit, but it does give you a bit of feedback. You've talked about the delivery plan, so I'm not really expecting that you'll go into that level of detail now, but would it be possible to get some kind of summary of what those might be so that we can kind of understand how are you going to monitor this? How are you going to review this? Is that possible?
Yeah, definitely. We can bring some updates, and I know that through the transformation work as well, you'll be getting updates on some of the deliverables and how they're aligned.
Any other questions? Oh, sorry. Councillor Richardson.
Can you hear me? Yes. Okay. Yes. This safe home, if people are not.
Councillor Richardson, I can't hear you. I'm sorry.
Okay. Can you hear me now?
You're going to bring it closer, I think.
No?
I can't hear you.
You
can't? All right, carry on.
Can anybody hear me?
Carry on.
Okay. Yes, for people who aren't happy, safe, able to maintain their own homes, what sort of provision are you thinking about?
Okay, shall I answer that one, Chair? Yeah. So if there is anyone who feels that they can't stay within their own home for whatever reason that might be, then they can come to, as they do, to adult social care, and we will work with them to consider their options and to consider if there are ways that we can help them to stay at home, first of all. And if they've been exhausted, then it will be around us embedding our approach. Our conversations will then happen with that person and with their family if they choose to have their family there, and then looking at what options are available to them and working with them to help them to achieve the options that are best for them.
Yes, I'm particularly concerned about people with no family, and very many live in very old homes, high maintenance homes. So for them, there's no plan to build more sheltered housing, for example, that they could occupy.
Yeah, do you want me to? Yeah, there's a couple of things if that's okay. We do have a handy van service that is really, really successful. They're obviously for very low level maintenance issues, obviously putting up a shelf or tidying a garden, which obviously actually does help with providing safety, people's perception of being safe, and obviously light bulbs. Very small jobs like that, and that is really, really successful. We do have also an extra care program, and obviously we've got the plans that are in place for Oakdale, that is the most one that we've got that we're working through at the moment. So that's at planning stage or going through to planning stage. But there is actually a housing group that we're looking at building our future provision going forward.
Because the other issue would be, even though those services are in place, a lot of people in that situation will not be very good at technology and communication to call handyman or the handyvan, whoever he is. So, if they have no family, then for them it's going to be very uncomfortable.
Yeah, that obviously feeds into some of the work around the transformation around our prevention program. We're just embarking on that. It's one of the work streams on the transformation, and that's exactly what the sort of some of the work that we're looking at, especially around loneliness, and really keeping people in their own homes for longer. and really trying to have that intervention, low level intervention upstream before they deteriorate or need that sort of support. So that work we're just literally starting that work.
I think also just to add to that, we know that we do have people living in our communities who don't necessarily come to services, but do have particular areas where they could really benefit from having some help. So I think in those kind of circumstances, there are lots of different routes in to adult social care, and it doesn't really matter what route you use to come in, as long as you're able to get access in. So it might be that if somebody goes and sees their GP and they recognise, or they have a chat with them and they believe that, adult social care could help, that they might talk to the person and agree, could they do the referral? Or if it's a friend, if it's anybody, a neighbour, anybody who comes into contact with them. And absolutely agree that we, there are people who don't use technology, and it doesn't matter how good your tech is if they're not able to do it. So we do try to put information in all of the spaces that we think somebody may go to at some point. But all that said, we do know that there are some people who maybe have very limited contact within their wider community, and we rely on others who may know of them to be able to come and let us know, so that we can work to support them in whatever way we can.
Okay.
Just one more point, Chair. So I think it's very important that the strategy is made known to people in that situation, because very often you're in that situation and you don't know what to do. So, yeah. Okay, thanks.
Okay, thank you very much. Councillor Salmon.
So in the budget scrutiny workshop last year, one of the things I really wanted to see was a direct link between expenditure and activity, and we weren't at a level where we had that kind of data maturity, and I can't see any mention of that kind of work happening within this strategy. So I was wondering if that was something, because that's for the implementation, for delivering the implementation, I feel that's key. And I just wondered, I know a lot of our stuff is on Mosaic, but just wanted to check, are we still in a situation where we've got 3 separate IT systems across Bournemouth, Christchurch and Poole? We're all totally integrated on one. That's brilliant. And I think that's... So it says we report into the ASCOF, whatever that stands for, the Adult Social Care Operational Framework or something, I think. And it doesn't... So it says that's a key measure for success, but I don't see any explicit targets within the strategy or reference to where we are. And I wondered if that was something I would expect to see. Like, here we are on this KPI, we're achieving, we expect to continue to achieve, but to reduce expenditure. If this one we're not, we're going to bring it up. Is that something that will be worked in?
Yes, I think the 3 things there. The first one that's easy to answer, yes, we're all on the Mosaic system now rather than 3 historic systems. So that's really helpful when it comes to performance reporting. The second one around budgets and directly relating to performance, I know there's some work going on with the transformation team. I don't know when you're bringing that, Tim, but I know you can give an update on that. Yeah, and completely. We have a lot of measures now, a fleet of performance indicators that we do monitor our delivery plans against. We haven't included any specifics in the strategy. I think we were trying to keep it high level and informative, but not weigh people down with information like that. But if it's something that we feel that we want to include, then absolutely we can look at that.
Yeah, I like smart targets, I like a clear, this is in 5 years' time, this will be so much better. I think that would be key. We're not making recommendations on this item, or we are? I'll think something up then.
Yes, as was mentioned earlier on, this hasn't actually been to Cabinet yet. So it might be an opportunity for us to make some recommendations. That's why I was, the Councillor Salmon's point is why I was asking about the delivery plan, because I'm kind of assuming that that level of detail is in there, rather than this kind of more high level report. So whenever it does go to Cabinet, I think you said the 2nd of April, it may well be that we would want to ask Cabinet to allow us to have a look at that have a look at those detailed plans and that data in a little bit more detail. Not sure, I'm looking across the room at Councillor Brown for some dissent, but I'm hoping that we might be able to do that. Did anybody see any issues with that? Okay, we'll find a formal words in a minute. Betty.
Yeah, and just to pick up on Councillor Salmon's point, just around the spend and activity, there is a lot of that work going on within transformation, within the Fulfilled Lives programme that comes to this committee for oversight and for scrutiny. And you have got a paper on that further on in the agenda, so that might be something that you might want to pick up a bit further in detail, either as a kind of conversation outside of this committee or within this committee. I know we've made that offer about picking up some points that maybe we can't fit into this committee, a bit like Councillor Sam, when you refer to the deep dive that I did with you and some other members, we can pick up some of that around the Fulfilled Lives, around the strategy, or the delivery plan, so that you're fully briefed on all of the areas that you want to, because there's some really good stuff going on and really important that we're able to share that in the level of detail that members want. Thank you.
Thank you, Betty. Yes, we're going to come on to the Fulfilled Lives thing in a minute. I guess I was just thinking about what else there might be in those delivery plans, beyond the Fulfilled Lives programme, even though there's quite a lot in that, and whether we might be able to get a bit of a handle on that. But we can certainly look at some of the issues that Councillor Salmon's raised under the Fulfilled Lives, unless anybody wants to make any specific recommendations on this particular item. Joe?
Yeah, so I think I'd probably make 2 recommendations, and I'm happy to have feedback on the language in case it's not clear or I've got something a bit wrong. But I'd say ONS, or whatever we call ourselves, recommends the inclusion of some clear targets, ideally linked to the ASCOF. I think I've got the acronym right. I guess we can check it post-production in the adult social care strategy. And then the second one would be the inclusion of an overview of how there will be better integration of performance and activity data with finance data in the adult social care strategy. And I think even if that is just a link to see this document in the transformation programme, but just something that says this is where you would look to see how this is going to be done. So those would be my 2 proposed recommendations.
We'll tidy up the words on that, but is everybody content that we try and do that, Betty?
Yeah, on the ASCOF, that's our national reporting anyway. So we have to report nationally through our client level data. So that's what that is. So we already report and link all of that in. So we can absolutely put, as Councillor Salmon said, links into the report for that, and very much similar on the finance. So they're both fine if we can just get some words from that. But we already do the ASCOF, and they are nationally set. So not within our gift to change, but we have our own extended version of some things as well that we're monitoring our performance on. And then just to add, this committee does receive our performance and quality, our PQIB, our performance quality and improvement board report into this committee as well, and that is everything to do with every line of performance within adult social care. So we have a performance quality and improvement board, and we have an exec board that is chaired by our chief exec and has the leader and our portfolio holder there as well, and that scrutinises and monitors every bit of performance that we're doing within adult social care. And Councillor Salmon, you particularly would probably welcome coming and just being there to see how that board works, and what kind of detail that we go into. So we can put links into that as well, which is all around the performance and the quality as well. Thank you, Chair.
Thank you, Betty. Are you happy you got captured those words?
Joe, could you just
I've
put them on the chat for the meeting? For
Yeah.
me?
Oh, yeah. On the chat for meeting. Yeah, I'll do that now.
Lovely, thank you.
Okay, is everybody happy with that? Oh, Councillor? Was that a wave?
I did put my hand up earlier because I had a question, but I don't know if you want to conclude this before I ask it.
Sorry.
Are you happy? Have you concluded?
If no one else wants to highlight, oh, Joe, you've spelt that wrong, or Joe, that's us about face or whatever. As long as everybody's happy with that, yeah, I'm happy to move on.
So the area that I'm particularly interested in, and I just wanted to perhaps get some feedback on how it's going, is your strength-based approach, your advocacy approach, and the adoption of the 3 conversations. I mean, obviously for some of your staff members, that's probably like business as usual, but I was just wondering how it was going with new staff, how the education, training, and more importantly, how the delivery of that's going, and whether you've had any feedback from your clients on whether that feels different and better. Thank you.
So, Chair, if it's okay, I'm going to ask Tim to come in on that because he's leading that work with us. I could answer it well, but would like Tim to have the opportunity to do that. Councillor Allen, please. Thank you.
Thanks, Betty. Yeah, no, absolutely no problem at all. So yeah, the 3 conversations delivery is proceeding still. At the moment, we've just completed implementation with the majority of our mental health teams, and our learning disabilities service is about to embark on their implementation next. So it's a staged approach, sort of going through in various phases, so that we've got the capacity to make sure we do it properly. In addition to that, we've had our autism team, our preparing for adulthood team have also undertaken that now as well, and all with really sort of positive feedback from not only from the staff but also from obviously the people that they're working with, finding it a much better approach.
That's excellent. I'd just like to hear about that in the future and how it's developing, and maybe even hear from some staff back about how they're finding it from their point of view. Thank you.
We would absolutely welcome that and love to bring some staff to showcase and to tell you the good, the bad, and the challenging within that. And just to add on what Tim has said, we've been working this programme. We had Partners for Change come in and work alongside us who are really skilled in this to make sure that we do it and we do it well. It's not something that happens overnight. We know that it's got longevity and you need to be in it for the longer time. So we've done quite a bit within our long-term conditions areas over the last year and a half. So now we're rolling it out everywhere else. And what that is absolutely beginning to show is that if people get the right conversation and the right support at the time that they come in, it enhances their independence level and really empowers people to tell us and work with us rather than us, going straight into an assessment of need, which is not always what's needed, but is often what happens because of just pace of work and all of that. But yeah, we would love to bring some practitioners. Thank you.
And just one more comment. I think obviously looking a bit into the future, but I think when you're changing an approach and a culture, you would hope that actually your staff will continue with that approach once they start to see the benefit of it. However, you've already mentioned pressure, and my experience in my day job is that when pressure comes, some of that quality tends to go and people are then just trying to rush through things again. And if you've worked in a sort of very much quick assessment, let's make a decision and move on to the next person. If you've done that for 20 years, for example, and you're now being asked to do a different approach, I'm just wondering what your plans are for consolidating that and moving forward and helping your staff to make that change a permanent thing rather than them sort of drifting back to perhaps an old ways because it just feels quicker and easier. Thank you.
Yeah, I think, and it's not easy, you know, and anybody who's really implemented a change, you know, that you want to sustain, you know, it is so difficult. And that's why it's taken us, we're taking our time, we're not rushing it. What we have done in one or two areas where we've you know, where Tim has worked with his peers and teams, they've said this is not the right time for us. Can you come back to us at another time? And they've paused and come back again because we've got to get it right, because we know it's the right approach. It really is better for the person and or the people that live with those and or care for them. But it takes time. We've been doing this now for, you know, over 18 months, and we're still rolling it out into some of the areas because you need to consolidate it and then take the learning and then bring it forward into the next area. So it's a real diligent piece of work. And we, you know, Tim and his team constantly ask staff for feedback, and our staff are very honest. Yeah, thanks. I think, Chair, just on that as well, Nikki just wanted me not to forget that she carries out lots of audits to see on casework, you know, real proper going into a case to see if it's personalised, to see if the person's voice, to see if their kind of what they want is coming through, and if the control and independence is kind of jumping off the pages. And that's been, you know, that's been a real change as well. It's not a prescribed assessment. It's more of a joint conversation approach. So we're constantly doing those as well.
Thank you. If any other points, I'm just going to ask Louise if you would just read back those recommendations, please. Thank you.
Thank you, Chair. The committee recommends the inclusion of some clear targets, ideally linked to the ASCOF within the adult social care strategy, and the inclusion of an overview of how to better integrate performance and activity data with finance data in the adult social care strategy.
Everyone happy with those?
Yeah.
Okay. Thank you very much. If there are no other items, then we'll conclude that item. Thanks, Nikki, very much for the presentation. We're going to move on to the ASC Fulfilled Lives programme. As you recall, we've looked at one of the aspects of this already, but this particular presentation is about self-directed support. I'm going to ask Tim Brownson and Betty to give us a bit of a presentation, please. Thank you.
Yeah, thank you, Chair, and evening, everybody. So, yeah, really pleased to have the opportunity just to come back and give you a further update on the programme. I won't go through all the details in terms of the history because you're more than familiar with that already, I'm sure. And as Chair was just saying, obviously we've got a programme of 4 projects within the whole programme, and we're focusing principally on self-directed support today, and also just to give you a little update on the benefits tracking as well. And I'm joined by colleagues in the room and online who will probably be able to field some of the questions that you may have as well. So in summary, the paper sort of talks us through the self-directed support update, which is focused on 3 key work streams. One is around the development of individual service funds. The second is around our trusted reviewers programme, and the third is around the development of community micro enterprises. And I think it's worth just saying that all of these things are very much aligned to the strategy and very much aligned to our general duties under the Care Act to provide person-centred support for people that need it, and that support is tailored and they have as much choice and control over the way that support is delivered to them. So in terms of those 3 individual work streams, individual service funds have been developed pretty much as a solution to those people who have had experience of a direct payment before, so you're probably all familiar with direct payments, whereby we just give the wherewithal financially to individuals to be able to design their own care and support. But that can have challenges for individuals, and they find it quite burdensome sometimes. So a solution to that is to enable somebody else to hold the money, and in this instance, it's the provider that they are working with. So this would be a provider that's on our framework that we've already accredited and approved through our new normal procurement processes. But so the partnership becomes between the person and the provider to work out between them how they're going to use the money that we've put into that person's personal budget for them to meet their needs and to achieve the outcomes that they're looking for in their sort of day-to-day life. So that's what individual service funds are around, and we've got a number of our framework providers who have opted to be part of a pilot, and they are working with a number of our individual clients now to sort of work that through. And Siobhan, you might be able to say a bit more about that if there's any sort of questions come up on that front. The Trusted Reviewer Programme, that's largely around the link to our day opportunities strategy and looking for more community-based options for people to spend their days rather than necessarily forcing them through to a route that is more doesn't have the amount of choice really, I suppose. So sort of traditional day services tend to be sort of very structured, and this actually gives people much more sort of flexibility and freedom. And then the community micro enterprises, again, that is linking to particularly for people in receipt of a direct payment, whereby they may have specific interests. So with the 3 conversations approach, we very much focus in on understanding what's really important to somebody, and what is important to somebody to lead a fulfilled life may be that we would expect then for them to be able to use their direct payment to undertake a different activity to one that they might traditionally be able to do through a commission service. And a community micro enterprise could be an individual or a small enterprise that would enable a particular activity that may not otherwise be available, but for somebody to actually sort of choose that activity and work with that provider to deliver it for them. So that's in essence the three sort of main strands on that. I don't know, would it be worth pausing at this point to sort of see if there's any questions on that part before I go on to the sort of second stage of the paper?
I was just wondering with, hang on, I'll have to look at the report here. The community micro enterprise, if they have to put their charge up, what happens to the person that we are funding basically to take that service? Because I do know locally in Christchurch that some of the CMEs, sorry, I'll get it right eventually. Yes, they have had to raise their charges for things, but obviously we need to then do something our end.
Okay, that's a really good question. Thanks. I mean, Siobhan or Kate, I don't know if you'd like to.
Yeah, no. If the charges do go up, they can come back to the team and they can make them aware. And then obviously, if their costs need to be reviewed, that can be done by the team that are responsible within the council to review that and obviously change the costs as necessary.
Okay, thank you.
Okay, do you want to press on?
Thank you. So that's basically the self-directed support project as it stands at the moment. And that's obviously an ongoing piece of work. And then in terms of the benefits tracking, one of the things that we said that we would do is just sort of come back and give you an update on the progress on that. I think where we're at this stage is we've now, we're just literally launching a savings and benefits subgroup. We've got the first meeting of that group tomorrow, which I expect will be sort of meeting on probably a weekly basis initially, and then sort of maybe as we make more progress, we might might be able to stand that frequency down a little bit. One of the biggest challenge, and is a widely acknowledged challenge, that trying to report financial benefits on preventative work particularly can be really difficult, because you're trying to prove a negative, if you like, and put a financial value to that. But we've come up with a methodology which basically involves looking at what our current spend is, and we do that in a way that we can look at individual slices by creating profiles of our client base based on either their age, well, a combination of their age, their gender, and their primary support reason, which is what we have to sort of denote their primary support reason as part of our national reporting. And by looking at each of those profiles, we can work out and calculate what our current average weekly spend is for a particular person of that meets those criteria. What we can then do with new people that we've not worked with previously, if they, depending upon what their profile is, we can match their profile to the existing profiles, and actually through the interventions that we're making with them in our new ways of working, we can compare that to what we would have spent on average for that similar profile in our old way of working, and in that way we can actually sort of come up with a differential, and that will denote what the saving has been. So that's a piece of work that we're just building up at the moment. There's some reporting functionality that we need to build within our Mosaic system, and we've got IT colleagues working on that so that we've got that as a mechanism that will be live and functional by the start of the financial year. I think that's probably the main sort of two main points to sort of draw out on that, actually. Betty, I don't know whether you wanted to say anything about future care. That was the other part, but
yeah, happy to talk about future care. So you will, Sam mentioned the word future care. So future care is the program of work that we are doing within our Dorset health and social care system, which also involves other partners as well. And this is where we are now, following a diagnostic exercise that we carried out a while ago with our strategic partner who are working with the Dorset system on this, which you know is Newton. So we're working with Newton to do that. And the diagnostic exercise identified substantial opportunities for improvements in health outcomes for Dorset residents, the wider Dorset residents, also reducing expenditure and releasing hospital and community beds, and also reducing the number of long-term beds in the community within residential care, and also looking at a reduction in domiciliary. So it's all about people living more independently. So when you look at the programme that we're doing within Fulfilled Lives, and you look at the Future Care programme, which has 6 work streams and 6 SROs, I am the SRO for the home-based intermediate care and reablement work stream. And when you look at those both alongside one another, they complement one another, and they both have programs that are going to be for a few years, 2 to 3 years. The Fulfilled Lives one is that, and it does have financial outcomes attached to it as well, as does the Fulfilled Lives. But the whole fundamental principles, I've just described a little bit about the future care, and Tim's done the Fulfilled Lives. It is all about improved outcomes for individuals, and particularly around the Fulfilled Lives, around enhancing and maintaining independence and choice and control, as well as being much more efficient and sustainable in the longer term. That's why the programs are not just 6 months or a year. They have to embed the changes in the culture and all of the stuff that we're trying to do. And the governance for the Home First, for the Future Care programme, is the System Executive Group, SEG, and a report will be going to SEG in March that will provide an update of where the Future Care programme is at and the work streams. And I'm very happy to ask if that report can be circulated to members. I have asked the director who is leading the programme director of the Future Care Programmes, to come, or the Future Care Programme, to come and provide an overview for this committee as well, and they're fair enough to do that. And I know that some members are maybe slightly concerned about, is there a tension between both programmes? And of course we have to be really, really mindful of that, because they both have separate outcomes attached to them, and as I've just said, separate efficiencies attached to them. Now, those efficiencies can come in many different forms, but that's why people like Tim and Harry, who is our programme project, team lead on this, they are also meeting with Newton colleagues and making sure that there's no duplication, and that we're not putting time and energy into areas that we don't need to. And that is the case for all organisations, because every organisation, every partner within the Future Care Programme will have internal organisational programmes running alongside that. Most do, and they're quite meaty programmes. But we absolutely believe that they're complementary to one another, and that you just need to be mindful of there ever being a tension in that duplication, and making sure that it doesn't happen, because none of us have time to duplicate. It's not productive and it's not effective. And some of what Richard showed earlier will benefit also from the Future Care Programme, because on one of those work streams there is an alternatives to admissions. And then the home-based intermediate care reablement one, that will take people home quicker. The initial focus may see the benefits coming from discharge, really enhanced speed of discharge in the right way for the right reasons, and people going on the right pathways. But that will absolutely benefit the community at the same time, because people will be able to come in when they need to into an acute environment and not have to wait and be deteriorating in their own environments, if that is the case. So, I think committee might want to really consider, and I know, Chair, you've already had a conversation about this, about the future care over, things coming to this programme as well as going to CMB and Cabinet as well. And I know that's something that Cabinet had most likely welcomed as well, because very much in line with the Fulfilled Lives programme that this committee is also having oversight of.
Thanks. I was just going to add, actually, because as I've neglected to mention, in the appendices to the report, you'll see there's a number of documents. So we've got the first appendix, which is a sort of a higher level set of performance measures, many of which are drawn from what we already report for our ASCOF, so what we were mentioning earlier when we were talking about the strategy. The second is a list of metrics that we've put together. This is more specifically around the How We Work project rather than the Self-Directed Support project. But again, it just sort of gives you an indication of the level of detail that we're going into for that. So this looks at demand coming through to our contact centre, and how that demand then translates through to subsequent sort of episodes of support. And where that support happens, and thirdly looks at the impact of the three conversations approach as well. Most of these are available now, pretty much. There are a handful that are still under development, and that's linked to some other changes that we're just implementing over the next few weeks with Mosaic and our three conversations approach, that sort of make the two sort of knit together. So again, I've probably a bit too much detail to go into in terms of the sort of technicalities of it all right now. But if there was, if members wanted to have a separate briefing on that, we could certainly arrange that. And then the final two appendices are some guidance that we had from the organisation that we worked with previously, Partners for Change, when we were first looking at implementing our three conversations approach. So that's basically just the basis on which we've then sort of built some of our own individual reporting mechanisms.
Thank you. I think it would be really helpful if we could get somebody from the kind of program management side of it to come. It feels a little bit like a jigsaw, and I guess there'll be somebody somewhere who is able to put that jigsaw together and tell us what it might look like when it's complete, and that would be really helpful. And to, I guess, offer some reassurance that there is some join up between what you and your team are doing within adult social care and what the hospital and the kind of more acute services are trying to do at their end. So that, I think that would be really helpful just to get that kind of clarity. So the other issue really is about how we might be able to review progress, because I saw in the papers that you've got, I think, 5 providers who are part of the pilot in terms of the individual service funds. And I'm just wondering, in terms of timescale, when it might be possible just to get a bit of a review of how that's going, and whether you think 5 is enough or whether you're going to need any more. And similarly with the community micro enterprises, I think I read you've got 3 potential ones. So again, I guess I'm just trying to ask really about timescales, about when it would be sensible to have some kind of review, see how that's progressed, and some kind of assessment of how that's working.
Yes, so in terms of the individual service funds, so we're staying with 5 providers at the moment who are on the framework. We're intending to to redesign and retender the framework, and that'll be the point at which we create a lot specifically for ISF providers so that we can accredit them as part of that framework. That's going to be happening over the next 6 months. So we will obviously contract and have a formal contract with everybody, hopefully within the next 6 months, and then we'll be able to open it out to more providers, but we want to make sure that we've accredited everybody to do that. So we can certainly provide a report on the pilot scheme with those providers and how we're going, because we're in stage 2 at the moment of doing that desktop exercise, and then we'll be moving towards actually applying that, or we can wait. It's entirely up to you. So we've actually accredited and report back on how many providers we've managed to source as part of the tender. So, I'd sort of defer to how you'd want to do that. The micro enterprises is an ongoing piece of work for the next 2 years. So we'll be looking to use the trusted reviewers to get that intelligence through co-producing with the people that are using services, and then try to drive as many and source as many micro enterprises to kind of meet whatever those needs are that we've been identified in the different communities. So again, we could come back perhaps in 6 months and just update, and then do another update as we kind of work through and see how that progresses.
Thank you. That's really helpful. Would be really helpful to get that. Could you just explain for the people who are dim as I am exactly what a trusted reviewer is?
So we've employed some people through the Community Action Network, and we've asked them to go and have conversations with people who are currently accessing day services. So as part of the day service strategy that was signed off in March this year, we had a priority to rebalance the services between the building-based and the community. So they're going into the building-based and they're saying, what would your best day look like? What would you like to be doing if you weren't in a building-based day service? They're telling us what they would like, and that then will help us to identify, do you want to be going out swimming, or do you want to be going to do volunteering, or what is it you want to do? And then they bring all that information together. They can sometimes source that from all the services that the Community Action Network are already able to access themselves in the communities, because they obviously already have those contacts. But they can also then give that information to the community catalysts and say, we haven't got that at the moment. Could you go out and see if you can source that, and perhaps work with some local people to develop those services for us as small micro enterprises?
Okay, thank you. Are there any other questions? Councillor Moriarty.
Thank you, Chair. I'm sorry, it's another question about community micro enterprises. So could I rock up and just say I want to create a community micro enterprise, or are there certain safeguards, or do people have to have certain qualifications, safeguarding, all of those kind of things? paying people? It sounds like a great idea to be able to give everybody everything that they want, but it sounds like it ought to be costly.
So that's why we've commissioned Community Catalysts to come in and work for us for a couple of years, because there has to be an accreditation process. So there has to be basic requirements, things like, the DBS process to make sure that people are safe to work with the people we want to work them with. So the Community Catalysts both support people to set up their business to make sure they've ticked all the boxes to be a sound business, but also that they can meet the standards that are required through an accreditation process. In order to be able to work with people that we're obviously supporting, or self-funders that are out there trying to source in the community.
Do you mind if I just very quick? So we are not employing these people. We don't employ community micro enterprises. Are they private? Are they?
Yes, so we don't directly employ the community enterprise. They would be employed by the person who's got the direct payment, or they would be employed by the individual service fund provider who's employing on behalf of the person who has the individual service fund.
Okay, thank you.
Betty.
Yeah, I think they're really, really good points, and points that need to be, there needs to be a very clear process for monitoring and evaluating. But what Siobhan is going to do, if the committee would like an update on a report to come back in 6 months or whenever you see fit, I think really outline which other councils are doing this, what they're doing. We're not the only ones. If anything, we're far from the only ones. There's a lot doing this. I understand, but Siobhan would need to clarify that even our neighbouring councils are doing this and have had really good success with it. And it's all about person-centred approaches and giving people the much more choice. But it does have to have those safeguards and those monitoring and evaluations. And I know that Siobhan will cover that in her briefing, but we'll also be more than happy to give any individual member any kind of briefings that they want, just so that you have that assurance, and that be satisfied that all those measures are in place. Thank you.
Thank you. Is everyone happy that we do that? We invite Siobhan to be interrogated once again about the details of this in around 6 months' time. Everybody happy with that? Can I just ask one quick question about the providers? So, in theory, is it possible that the provider could say, we can provide you with X or X and Y, and then you can say to anybody who's looking for those services that they are available? What I'm really saying is the service that those providers can offer you, would it be available to more than one individual or group of individuals?
Certainly, it depends on the service. So if it's perhaps a personal assistant for somebody who wants to be out and about, then depending on how many hours that person wants depends on whether they're available to somebody else. But we've certainly got micro enterprises already that are running groups, and so they would run together, so that there's perfect opportunities to work with more than one. We will be looking at how we provide information to make sure that people that we're working with, but also self-funders, can get that information and see who's out there, whether we do that through the Community Action Network or through our own websites. We will be doing that. Just to add, actually, in terms of the accreditation, the quality side, the Day Opportunity Strategy also has a priority around quality assurance. So we are going to be co-producing with people with lived experience, with our providers, some a quality assurance framework, and we're looking at how we can do peer reviews. So there's a whole structure within the day service around how we can enhance quality standards, how we can review and monitor that. So we can also talk about that as part of the Day Opportunity Strategy as well.
Okay, thank you very much. Councillor Richardson.
Yeah, the providers, they are for profit-making businesses, yeah?
Yes, all our providers do make profit, even our commission providers, so they would be allowed to, yes, make some profit out of it.
Okay.
Okay, any other questions, any points? Councillor Salmon.
Oh, I'm just curious. When you say they can make a profit, I would have thought this would be an area where you would see a lot of, not exactly charitable, but community interest companies and so forth. Is that something that you see existing in the ecosystem? Or is it all very straightforward, I don't know, Bupa or smaller versions of Bupa, you know what I mean?
So community catalysts have to be 8 employees or volunteers and less. So they are much smaller organisations, which means they have much smaller overheads. And we've looked at different local authorities. And for example, with Somerset, they were seeing quite a significant reduction in cost for the same sorts of services. So the data's a little bit old, but if we looked at 2020, on average, a home care provider was costing the local authority about £18 an hour, but a micro enterprise was costing £14 an hour. So there was a significant difference in the cost because obviously as a much smaller organisation, you were able to provide that without the overheads that a large organisation would have to include in their costs. But you're still getting the same service and you're getting a more localised service in many cases. But yes, community interest companies.
Okay, any other questions, any other points? Thank you all. Oh, Councillor Edwards, sorry.
Thank you, Chair. It was just a question, it's only been mentioned very briefly about self-funders. You're saying you get a lot of calls, 1,500 calls last year. And I just wondered how many came in and were under the council wing and that they paid for the support, and how many you helped with, you had to signpost onto self-funding with, you know, the daycares and all those sort of things. I just wondered if you sort of separated the costs that occurred, because obviously you've got an initial cost, haven't you? Because you're dealing with the phone call and the time spent with them, signposting them. And so I just wondered if the costs were sort of separated out.
Yeah, so that would be in what Tim was sharing around the number of people that came in for, you know, whenever you were doing the statistics around the number that the contact centre were able to pick up and work with. Anybody can come into adult social care, as you know well. Anybody can come into adult social care and can ask for care and support and information depending on, you know, where they're at in their needs. Certainly within the Care Act, we have a duty and a responsibility to people irrespective if they fund their own care. And at the very least, that is making sure that people that fund their own care, that we are providing them with the right information and being able to signpost them on to areas that can and will support them. The actual breakdown that come in, a lot of the time coming in, and they will have a conversation with the practitioner who they're on the phone to, and some of that might be as simple as just asking them for some information, and it mightn't even get to that bit of the conversation. Do you fund your own care? So we do have statistics, but the statistics would lack in, you know, depending on what that piece of intervention was. But if you wanted, you know, really break down detail of how many were people that went on then to have a service that was supported financially by them having a Care Act assessment and being eligible under fairer charging for assistance from the council, then we could provide that. But what I would say is that unless they had a commission service, you know, whatever form that commission service might be, and unless they went on to have a Care Act assessment, that then in turn created a financial assessment, we wouldn't know that detail at the very early stage. And the contact centre is about dealing and, you know, being able to manage the work that comes in there instead of doing handoffs. Where if somebody went into the contact centre and it was very clear they had a long-term need and it needed to be a commissioned need and all of that, then they would go into one of the longer-term teams that then would be able to work with them, and we have all those statistics in our long-term. But the bit that Tim was referring to was very much around the contact centre. So very happy, Councillor Edwards, to provide you with any statistics. Is that okay? Thank you.
Okay, anything else on that? If not, can I thank everybody for their help with that? And I'm going to move on. I think it's Councillor Brown next, portfolio holders update. Thank you.
Right, thank you, Chair. Actually, just before I do my sort of reasonably brief portfolio holder update, I just wanted to, on that last point actually about the community micro enterprises, and I think, you know, we've had these sort of small organisations and some voluntary, some sort of profit making, operating for many years. Actually, you know, I've known people just like two-man bands operating weekly clubs for people with learning disabilities, and so they've always been there. But I think with the day opportunity strategy, it's about expanding that and extending that and bringing more groups into that marketplace. And for me, one of the really important bits of the day opportunity strategy is that quality assurance bit that was mentioned, because a lot of these groups have operated for many years and we get DBS checks, and, you know, they've probably got safeguarding policies and all of that, but it's really important that we actually know and understand that a bit more, and actually that we can sort of have some quality assurance. So for me, that's one of the really important bits about the day opportunity strategy, is actually having some oversight of that market, really. Just for my portfolio holder update, I was looking through my notes, and since the last meeting in December, it's very much been about staffing stuff. We've had interviews and appointed Rob Carroll as the new BCP Director of Public Health and Communities, who's will be starting from the 1st of April. So that's been a big step forward. As well as on the Tricuro side, also sort of in December, January, we've had interviews and appointment of new Tricuro senior management. So the new chair, Jan Bergman, new Chief Executive Officer, Marianne Wanstall, the new Director of Finance, Peter Nell, and as a result of that, the departure of the interim Managing Director, Derek Law, who, although interim, spent over a year, I think, as the Managing Director of Tricuro, and saw them through a lot of sort of tricky issues and sort of steadied the ship, really. As well as then, sadly, the announcement at the end of January of the forthcoming departure of our Corporate Director of Wellbeing, Gillian. So having accepted the position of the Chief Executive at Southampton City Council. So yeah, I think that, you know, that's a blow, I think, because I really sort of appreciated sort of Gillian's sort of advice and direction, strategic thinking. So we're looking at the sort of recruitment process, and the options are under consideration following that announcement. So other than that, really, all the sort of staffing and recruitment side of things, it's very much been about progress on the areas really mostly that have been presented this evening around adult social care strategy, adult social care transformation, the future care work with Newton, public health disaggregation, day opportunity strategy, and last but not least, the CQC inspection preparedness. I won't say preparations because it's sort of constantly kept on the boil ready for it, so it's sort of just about preparedness really for CQC inspection. And that's very much really where we are.
Thank you, David. Any questions for the portfolio holder? Okay, thank you very much indeed. Don't go too far away, David, because I might need you on the next item. So going to move on to the work plan. So what you have in the papers is an updated version of the work plan. And as you can see from that, we have got kind of roughly mapped out the issues that are coming forward for the next month or so, or next few meetings rather. And also at the end, our usual kind of running list of things that are on the work programme, but we haven't yet slotted in a particular time for. So I'm just going to take this slightly out of order. So we've got from this evening a couple of things that we will need to fit in to the work programme. We will try and do that. And we have got both a briefing booked in for April and the full meeting of the 19th of May. So we will try and use those dates to work around the issues that we've been discussing this evening. But the other thing I just wanted to mention before I forget is that following the consideration of our recommendations to the Overview and Scrutiny Board, or to Cabinet actually, about the budget, the Overview and Scrutiny Board did ask us to look at the issue of block booked beds, and we will try and find an opportunity to have a look at, see how that's going. We did get an update from the portfolio holder as to how far they've got with that already in terms of the response to the budget, and that was really helpful. So we'd obviously want to have another look at it at some point to see if we can get to that magic figure of 300 that we set ourselves a target for. So with your agreement, we'll try and build those into the work programme. Is there anything else on the work programme that anybody would like to raise? Okay, that's fine. If you think of anything, just shout. By the way, it's not the you don't have to do everything within the formal meeting. If there's any issues that you think we need to highlight or bring forward, please just say so, and we'll do our best to try and accommodate it. So before I close this meeting, I just wanted to pick up on the point that Councillor Brown's already mentioned about the departure of Gillian Kay as our Corporate Director of Wellbeing. That she wasn't able to join us tonight, and this is probably going to be the last meeting of this committee before she leaves. So I would, with your agreement, like to record in the minutes our thanks and appreciation for the work that she's done on behalf of the council, and also to assist the work of this committee, if you're agreeable with that. Is that okay? Yep. So thank you very much, everybody. I'm going to close the meeting at that point. So thank you for your help.